Thank you very much. I'd like to start by thanking the organising committee for the opportunity to present. I'd also like to thank them for squeezing me in amongst three giants, Professor Esbista, Professor Fraser and Associate Professor French. It couldn't get any more uncomfortable. So by way of declarations, it's important that I indicate that this presentation has been cleared by Joint Health Command, as have all the images. And with respect to acknowledgements, I'd like to publicly acknowledge my colleagues who make it feasible for me to abscond for several months at a time and pick up the slack. In that regard, when I think back to a band of brothers and sisters, in a short 4.5-month period, the bonds that you create with people that you work alongside under sometimes adverse conditions are incredible, and they generate long-lasting and enduring friendships. But most of all, I'd like to acknowledge our patients who teach us so much. In the next 20 minutes, what I'd like to hope to achieve is review some of the aspects of the National Blood Authority patient management blood guidelines, particularly with reference to critical bleeding and massive transfusion, which is Module 1, and those of the critical care module. And in that context, I'd like to reflect back on a busy trauma centre. Now, by way of the guidelines, I guess if I stopped right here, you would have gained something. Those of you who have not gone to the booth, you should. These are 2 of 6 projected guidelines that have been published. The critical bleeding module was published in 2011, and the critical care module is fresh off the press as of March this year. And I'd commend these guidelines to all of you. In essence, they replace the guidelines for the use of blood components, and you'll see there's a paradigm shift there in that we now talk about patient blood management guidelines, putting the patient first and central in the process. Just a brief overview of how these guidelines are generated. There's various working parties, if you'd like, that surround each module, and questions are formulated that will be useful to the clinician, and then those questions are then extensively searched. Systematic reviews are undertaken by professional reviewers. The evidence is returned, and based on those findings, if there's strong enough evidence, a recommendation can be formulated, and in those instances where that's not feasible, a practice point can be generated if it's felt that the clinicians would benefit. At the end of the day, patient blood management aims to improve clinical outcomes by avoiding unnecessary exposure to blood products, and essentially comprises 3 pillars. The first is optimizing blood volume and red cell mass. The second is minimizing blood loss. And finally, the concept of optimizing the patient's ability to tolerate anemia. Now, recently I returned from Kandahar, Afghanistan, southern Afghanistan, where I had the opportunity to serve in this establishment. You'll recall from the title of the talk, Lessons from the Front Line. I've now exposed myself as a fraud. That hardly looks like the front line. That is a rocket-proof hospital, and inside of there is a state-of-the-art trauma centre. By way of understanding the centre, there was a nice publication done by the Canadians who served there a couple of years before. They admitted 188 intensive care patients in their 4-month rotation. 46% of those patients were the result of improvised explosive devices, and 26% of those patients were the result of high-velocity gunshot injuries. You'll see quite how sick these patients were, with injury severity scores in the order of 37. And 81% of these patients required mechanical ventilation for a mean of 3 days, with an ICU stay in the order of 4.3 days. But probably most proudly, a survival of 93%. My rotation, or the rotation I was on, was April through August this year. Our numbers were similar in that we had 150 ICU admissions, 87 battle injuries, and again, most of these injuries resulted from improvised explosive devices, high-velocity gunshot wounds, and rocket injuries. Now, the management of the critically bleeding patient focuses on early recognition of blood loss, which when you look at an image like this seems very intuitive, but in fact it's not. It's the small penetrating wound in the right hypochondrium that in fact catches you in this patient. It's hard to imagine that you would ever have humour in this environment, and those of you that have subscribed to MASH would be able to relate. The environment is very, very similar. And the day this fellow came in, we had 6 similar cases all coming in simultaneously, all from the same battlefield. They'd all been injured about 15 or 16 minutes before and airlifted into us. And one of the fellows came in, and as he came in, he was asked, do you have any medical problems? And in this Texan drawl, he said, well, hell yeah, I don't got legs anymore. Which stuck in my head, like just the fact that he was so, aware of his situation. But the important thing is to stop the bleeding as soon as possible. If we look at early data from the global war on terror, Holcomb looked back over 82 Special Forces soldiers who had died, trying to seek out who of them with different medical care or better medical care could have survived. And he found that 85% of these patients were unsurvivable under any circumstances, but 15% of them could in fact have been salvaged. And probably most worrying of that 15%, 33% had extremity hemorrhage as a cause, and that generates a key focus for intervention. A similar study again demonstrates that of the preventable deaths, 85% of them are secondary to hemorrhage, and this is therefore where we have to go to make the difference. The whole focus of that hospital is hemostasis, and it's no different to what everybody in this audience is used to doing, except there's an emphasis on the use of tourniquets and topical hemostatic agents. And if you look at the National Blood Authority patient blood management guidelines, you'll find that it makes it clear that these agents or utensils are of some utility. Now, these 2 images that you see up on the screen, I think on your left-hand side is an unfortunate gentleman who was the victim of an IED explosion. You'll see he's got extensive facial and soft tissue and bony facial injuries. On your right-hand side is a distal femur fracture secondary to a high-velocity gunshot wound. What is unique that you don't see is this radio-opaque material that shows up on that slide. And in fact, these are topical hemostatic agents that are commonly used over there, and all the combat medics and corpsmen are indeed carrying this material with them. It has the advantage that it's topical. It supposedly accelerates the coagulation pathway by a variety of mechanisms and can be used in junctional and non-compressible sites. There have been a myriad of agents, and at the start of the war, zeolite in the form of quick clot was used. This agent dehydrated the clot effectively, enhancing the concentration of coagulation factors. But its downfall was that it generated an exothermic reaction that was at the very least uncomfortable to patients, but in fact also several patients incurred burns. The product has since been changed and modified, but in that time we've moved to a kaolin-based product, which is what we use now, combat gauze, and that was what you saw in those previous pictures. Shifting gears and going to tourniquets. At the end of the Second World War, tourniquets fell out of vogue. Sadly, they were not used throughout the entire Vietnam conflict, and a recent study looking retrospectively at the 58,000 deaths from Vietnam suggested that, in the US forces, suggested that 2.7% of those may have been salvaged if tourniquets were in use at that time. Furthermore, we've been able to demonstrate that there's low complication rates with their use. The things we previously feared are in fact not real concerns. And there's a positive survival benefit. Craig has done most of the work in this field, and this is a composition of 2 lots of data sets that he had, giving him nearly 500 patients, and looking at the survival rates with and without tourniquets. What is interesting is that without a tourniquet, there's no survival if your limbs come off. With it, the survival is very acceptable. What is important, if you look over here, if you look up over there, you see that what's really important is when you get your tourniquet applied. If you delay it until shock has evolved, then your mortality benefit is essentially lost. And the bottom graph just simply says the same thing if you get your tourniquet applied in the pre-hospital environment versus in the post-hospital environment. Then shifting gears again, if you look in the blood management guidelines or patient management guidelines, you'll find out that permissive hypertensive resuscitation is considered a reasonable thing to do. Certainly that was the standard in the NATO Role 3 hospital. No patient was waterlogged or over-resuscitated for obvious reasons. And I should point out that the American mortality review and morbidity review was incredibly stringent. So you knew that even the slightest error or overshoot would be reviewed with some disdain. Taken directly from the guidelines, the reason that we avoid over-resuscitation is because of the risk of edema, compartment syndrome, and the potential to cause an acute respiratory distress syndrome, but also the potential to exacerbate anemia and the dilutional coagulopathy, and all the while potentially posing a risk for mechanical disruption of clot. But not everybody's suitable, and those with head injuries require a cerebral perfusion pressure, and so they need to be eliminated from that strategy. We don't know what the safe level of permissive hypotension is. We don't know what the safe duration is. What we do know is it probably needs to be individualized and that you need to be exquisitely careful when you're dealing with the elderly. Massive transfusion is a daily occurrence in Kandahar, and by whichever definition you wish to work, clearly something that's real-time, like how many mils of blood you're losing per minute, is advantageous, but it's not always oftentimes available to you. So what then is the utility of a massive transfusion protocol? Well, certainly when you're in a base that's got 30,000 people on it, and you have the potential at any time to get 20 or 25 people requiring massive transfusion, you need some structured way to provide those products in an appropriate way at an appropriate time. And this was managed very carefully in the hospital. Every single morning we would have a command meeting, a command round, and the CO would be presented by the laboratory staff with the exact status of our blood products in the hospital and when more would be expected and what had been used in the preceding 24 hours. There's been a fair bit of work done out of the global war on terror on this, and in fact McLaughlin did some work looking at what were the best predictors of when to mobilize a massive transfusion, and those factors that you see on the left-hand side of the screen there, tachycardia, hypotension, acidosis, and a drop in hematocrit seem to be as useful as a revised trauma score. So that brings us to the first recommendation of the guidelines, and it is recommended that institutions develop a massive transfusion protocol. So those of you sitting in the audience that don't have one in your hospital, I would strongly urge that you go down to the stand, pick up a book or get to the website and download the template and institute that for your hospital. Now, the practice point to come out of that is that probably lives are saved and complications are avoided by the use of a massive transfusion protocol. That's just an example. Any massive transfusion or a template, and this is very similar to the one we used in Kandahar, you need to mobilize it, something needs to trigger it. Then you need to know what parameters you wish to follow during the process. You need to know what products will be delivered, at what rate they'll be delivered, and ultimately you need something that'll switch it off, and you also need to know who's going to be involved in that process. So when we've got patients that are critically bleeding and requiring a massive transfusion, what parameters should be measured and what should we be doing with them? And I think I worked for Dan Maloney about, I think it must be probably 8 or 9 years ago now, and he always used to say, do the small things well. And that stuck with me, and as I've gone through my career, it's become more apparent at how important that is, because there's nothing particularly clever here, but it's just making sure you stay on the small things well, and that's indeed what we did in that hospital. So what product ratios should we use, and how should we optimize our resuscitation of hemorrhagic shock? Another bit of light humour that sticks in my mind that I hope doesn't offend you, but it always gave me a bit of a laugh. one of the days that we had several of these US soldiers come in at once, one of the fellows had just freshly had his legs amputated, and he was conscious and alert, and he had this, obviously had his tourniquet still in place, and I saw him turn to the corpsman, who's his age as well, about 22 years old, and he says to him, how's my pecker? And I wondered how the corpsman was going to handle that, and he took the linen and folded it down, and he looked and put it back. He said, better than mine. All right, if we look at, we want to answer the question about product ratios. It's apparent that there's been a lot of retrospective studies, all of them potentially suffering from survivor bias and the quality of data questionable. And that is why we could only generate a practice point from that, suggesting that there's insufficient evidence to refute or support any particular ratio. In the Role 1, we were using a 1:1:1 ratio, as often as was feasible by virtue of product that was available. We need to wait for the results of this trial, which should be published in 2015, which will be looking at 24-hour and 30-day mortality, and hopefully will provide us with the answer. One drawback is that it's a 1:1 or a 1:2, and maybe that ratio is too close for us to find a massive amount of benefit there. What the guidelines do give us is a suggestion with respect to dosages, and again, this is very similar to what we were using overseas. So what's a hemoglobin trigger? We know from standard critical care that a hemoglobin of 70 to 90 would seem reasonable. What's the trigger for somebody that's acutely bleeding? And quite frankly, there is no answer to that, but what we can say is that this is best interpreted in light of the hemodynamic status of the patient, the organ perfusion, and of course tissue oxygenation. And finally, just in the home run, what adjuvant therapy should we employ and what were we employing? And that gives rise to the second recommendation from the critical bleeding module guidelines. And the routine use of recombinant factor 7A is not outlawed, but not recommended. And the basis for that was grade B evidence. And I guess that the risk of harm since the 2010 New England Journal safety trial, or safety data on factor 7 had really put pay to it. Having said that, we didn't use an ampule of this product overseas at any one time, although it was considered. And that's interesting because our practice point there is don't write it off completely. Have it in the very low down in your armamentarium on a massive transfusion protocol. And where survival is a credible outcome and all other avenues have been exhausted, it leaves the door open for us to consider it.